Hello, everyone, and welcome back to the Gaining Health podcast. I am so excited and honored to have our guest here today. We have Dr. Donna Ryan with us, and she really doesn't need an introduction, but I will give you her very impressive introduction anyways. She is Professor Emerita of Pennington Biomedical Research Center, a campus of Louisiana State University in Baton Rouge, where until retirement, she directed clinical research for 22 years. And her own research includes participation on the teams that developed and executed studies that we are all very familiar with, such as the Dietary Approaches to Stop Hypertension, or the DASH studies, preventing overweight using novel dietary strategies, or the Pounds Lost study, the Diabetes Prevention Program, or the DPP, and the Action for Health and Diabetes, or the Look Ahead study. So again, these are such sentinel studies that you've been involved with. And she's continued her interest focusing on the translation of effective weight management into primary care. And she's the past president of the Obesity Society and has served as the panel co-chair to revise the NIH-supported evidence-based guidelines on the evaluation and management of overweight and obesity in adults. And her scholarly activities include authorship of more than 200 original publications and 45 books, chapters, and reviews, primarily in the field of obesity. And so I'm just so honored to have you here with me today, especially after we just celebrated International Women's Day and Obesity Care Week. So you have just been such a prolific leader and trailblazer in this field. And as a woman, I just admire your work and you so much. So I'm so grateful to have you here on the podcast today. Thank you so much and welcome, Dr. Ryan.
Karli, I am honored to be asked to be here. Thank you so much for inviting me.
Oh, this is great. So, Donna, first thing I want to get into is how did you get involved in the field of obesity medicine and the research? How did all of that start for you?
You know, I'm a medical oncologist.
Okay.
So it's not an intuitive leap.
No.
But you know, like a lot of women, I was always tied to Louisiana, and you know, because of my family. And, you know, when they get older, when your children get older, they get quite vocal. They don't want to go anywhere. So I always knew that my destiny was to stay in Louisiana, in New Orleans, or it's where other places around it. So I had gotten into doing some administration for LSU Medical Center, and we had a wonderful donation. Doc Pennington, C.B. Pennington, gave LSU a huge gift, the largest ever given to a university at the time. And he wanted to establish the Pennington Center dedicated to research in nutrition in Baton Rouge. And so I was asked by the university to help recruit the first director and get that first director established in Baton Rouge and the Pennington Center. And that's how I met George Bray. So I owe everything to George Bray. He is the father of obesity research. He's now 91. He's doing very well. And Karli, you need to interview him.
Oh my gosh, yes.
Yes, he would give you a really interesting interview too. So he was our first director, and I was there mostly to help him get the center started. Administratively. I have to say, you know, I was like most physicians at the beginning. You know, I heard his area of interest was in obesity research and treatment. And I remember saying to George, now, George, isn't the problem with just eating too much and exercising too little? So, Karli, I was where all of the doctors were. I thought it was simple. Well, just tell them to eat less and exercise more. And I have to say, you read off that list of studies, and those studies really educated me about obesity, about how hard it is to lose weight, how difficult it is to keep the weight off, what's going on that drives those things. I really learned from all the scientists at Pennington who really educated me.
Yeah. And I was there too before I learned about obesity, and I had done a lot of training in exercise physiology and nutrition, and I'd gone through my whole PA training. And I really wanted to help patients with weight management, with disease prevention, with lifestyle. And I was finding the same thing, that I just kept running into these roadblocks. But I too had these preconceived notions of, well, if people just ate better and moved more, then wouldn't that take care of the problem? And it honestly wasn't until I accidentally fell into a job in bariatric surgery and went to my first ASMBS conference that my whole, world just blew up, and it blew open with all this science of all these hormones and all of these things I had no idea about. So yeah,
we owe a lot to our bariatric surgeons for really showing us the way and for really pointing to the physiology that's there.
Yeah, because I remember this was around 2011, 2012. And I remember thinking at that time, well, gosh, now that we know all of this about all these hormones and the changes that happen in bariatric surgery, how can we take that information and then apply it, medically? And so it's really been cool. I'm sure for you, having been there since way before that, and seeing all of this transpire throughout these years, and just the science and the understanding of obesity as a disease, it's been really cool and fascinating to watch just the last 10 years. But I'm sure over the last, however long you've been involved with this, I'm sure you've seen an incredible change.
Our bariatric surgeons really showed us the way. But when you talk about 2012, at that point in 2012, we had no new medications for weight management. And it's really been interesting over that last decade, to see what has transpired. And really the GLP-1 receptor agonists that really were promoted partly on the basis of our understanding of what happens to those hormones, those gut hormones in bariatric surgery. We knew they were effective in diabetes, but really promoting them for weight loss was a big leap.
Yeah.
And thank goodness Novo Nordisk took it, followed by Eli Lilly. And now we have medications that are producing substantial weight loss, the amount of weight loss that our patients desire. Yeah. So, for example, semaglutide, made by Novo Nordisk, produces on average about 15 to 17% weight loss. And Eli Lilly's drug, which is under review by the FDA right now, it's producing on average about 22% weight loss. So really, it's learning from the biology of obesity that's produced these results. It's really amazing. It's been so rewarding for me. I got started as the lifestyle lady.
Yep.
Because all my studies were doing lifestyle. They were diet studies like DASH. They were studies of DPP, the Diabetes Prevention Program, the Look Ahead study. Those were all intensive lifestyle intervention studies. And so my career was built on, modest weight loss can have good health effects. But look, Karli, more weight loss is better.
Yeah, I loved what you said in your presentation at OMA. And I was just saying, I am the self-proclaimed queen of the benefits of 5 to 10% weight loss, because that's all we could produce. And now, now with these newer drugs, we're able to really get even more weight reduction and more health benefits that we see from that. So, yeah.
It was really hard, I think that 5 to 10% weight loss, it is great. It's great for diabetes prevention. It has a lot of positive health benefits. But look, patients want more weight loss, and we need to be able to give it to them because it also produces more health benefits.
Yeah. Yay. Absolutely. I mean, when we start looking at, again, going back to bariatric surgery, where we actually are able to see reductions in cancer rates, reductions in mortality. And those are some of the things, and cardiovascular disease. And so those are some of the outcomes that we haven't been able to see yet with some of these medical therapies. But I'm sure, what is your thought with some of these new treatments? Do you think we're going to start to see some of the benefits there as well?
We'll find out this year if the SELECT trial reports out positive. It's a cardiovascular outcome trial, and it will be a landmark. Yeah. So it'll be the very first of those important studies that show that weight loss aided by these medications actually produces benefits in terms of what we call hard endpoints, cardiovascular events like stroke and MI. Later, hopefully there'll be other studies looking at cancer endpoints and others. But we know weight loss is good for you. We know this ought to work. We haven't been able to prove it. because we haven't been able to produce enough weight loss.
Yeah.
I don't think that even these medications are going to ever replace bariatric surgery. I think they're one tool in the toolbox. I don't think lifestyle intervention is going to go away. It works for some people, and it's so safe and it's healthy. So lifestyle intervention, medications, bariatric surgery, they're all tools in our toolbox, and we need to know how to work with all of them.
Right. And I think ultimately that's when we get the best results, right? When we combine all of these things, it's not one thing or the other. It's the combination of these tools that we have and then being able to individualize it for each person. And so coming back to the lifestyle.
System.
Yes, right? So coming back to kind of the significant weight reduction that we're seeing with some of these medications, are there any concerns that you have about that? Anything you're worried about prescribers using these medications and perhaps not using some of the lifestyle components along with them? Or are there any concerns that you see right now with these medications?
There's such demand. We see these social media stars and movie stars who don't need to lose weight taking these medications. We see other, internet billionaires who want to take them. They might need to actually benefit from them. But,
right.
The point I want to make is that these medications, every medication has side effects, and it's important that we use these medications for health benefit. These are not approved for cosmetic benefits. So that's the first thing. It's really important to understand in our weight loss, every treatment that we have, there's a great variation in response. Some patients do very, very well. Some patients do pretty well. Some patients don't do very well at all. But there are some super responders. And so for the first time with medications, we're seeing patients get down to not just overweight status from obesity, they're getting down to normal weight status and to the lower limits of normal weight status.
Yeah.
So for the first time, we're having to taper and reduce our doses to keep patients within a healthy weight range.
Yeah.
So there, we also worry. So there's the worry about losing too much weight, losing weight too fast. We don't really want people to lose. We want people to keep eating.
Right.
We need our nutrition, and we don't want people to stop eating and to lose weight like starvation. We know that is very unhealthy. Mm-hmm. You have to have a certain amount of protein intake to maintain your cardiovascular function. Right. And we know from our old studies where we put patients on diets of less than 500 calories a day and didn't have a high quality protein source for those 500 calories, that those patients got cardiac arrhythmias and some deaths. So we want to maintain protein intake. We want to maintain good nutrition, vitamin intake, electrolyte intake. So we don't want people losing weight too fast. We don't want people losing too much weight. Mm-hmm. And we want to be very careful about not just losing weight. What we're trying to do is to get people to lose fat, right?
Yes.
Obesity, yay! Obesity is excess abnormal body fat.
Right.
And so we don't really want people losing lean and fat, too much lean, and so the bariatric surgeons are really good about this. They really enforce the physical activity, especially weight-bearing physical activity and the, weight training. And we need to copy this with these medications.
Totally.
Because we need to.
Yeah, I could not agree more. And the protein intake, and this is why I kind of like that I started out my work in obesity and bariatric surgery. So that was just drilled into my head, to make sure that patients are getting their bare minimum of 60 grams of protein and probably need more, most patients, to make sure that we're not losing that muscle mass, to make sure they're doing resistance training. So I think that is one of my concerns where we're suppressing appetite as much as we are with these medications, and they're not receiving the counseling about ensuring that when they eat, they're eating the right foods and that they're getting sufficient protein and that they're doing the resistance training and the weight-bearing activity to prevent that muscle mass loss. Because otherwise we could end up with an epidemic of sarcopenic obesity, right? All this wasting of the muscle mass, and that can bring with it its whole other host of problems. So yeah, I think you're absolutely right. And that's where I think we can really learn so much from our bariatric surgery colleagues and make sure that as we're prescribing these medications, also in primary care and in other settings, that the patients are receiving this counseling as well to go along.
Absolutely. Thank you. Help me do that.
I will try. I'm going to do my best to get that message out there. So I know you and I are both very involved with educating clinicians at all kinds of different organizations. So making sure that that message is loud and clear that yes, these medications are very effective. And we should make sure we're doing the lifestyle counseling along with it, especially the protein and resistance training to make sure that we're losing, like you said, adipose tissue. We're not interested in weight loss, really. We're interested in adipose tissue loss. And that's where I think, body composition analysis and all of that is an important part of it too. So I know we talked about that a little bit recently about, how we can get body composition analysis to be something that's utilized more in clinical practice.
I hope one thing that will take off is the use of digital anthropometry. So what that is it's a, it's a way of using a camera on a cell phone or an iPad, and you take a picture, 4 pictures in your sort of, in your exercise outfit that's pretty tight, like a bathing suit. So you take a front, a back, and each side. And then that camera is so good at measuring the circumference. If you have all 4 of those, you can measure the circumferences from top to bottom. And if you know the weight and you know the volume, you can determine the percent body fat. So I'm hoping that these, now there are lots of different apps that are out there trying to do this. Amazon has one that's available. It's paired with a watch. There's another one. It's called, I think, Me 360, and anybody can download Me 360 onto their iPhone or your. It doesn't have to be an iPhone. It can be any sort of phone that downloads the apps, and take your picture, and you can determine your own body fat. So I'm hoping, this digital anthropometry, it's something that we could work into our practices already. Our Department of Defense is using this for the annual physical fitness test for the soldiers. We used to do taping of our shoulders. They had to have a height, weight. We'd measure the neck circumference. We'd measure the arm circumferences, the chest, the waist, the hips. And, because in order to be promoted and in order to be deployed, you must pass every 6 months a physical fitness test. They no longer do the taping. They do digital anthropometry. So I'm hoping that this can be developed in our practices because it's such a convenient, cheap. Yeah. It's almost free, and it's low cost, and it's not invasive, and it's safe. It could be a really great way to follow body composition. In the meantime, I hope your listeners will all investigate digital anthropometry, because if they're interested in their body composition, it's a pretty good way to determine what it is.
Yeah, I love that. And I looked into it more actually after the last time we spoke, and you mentioned it. And it's so cool because our patients can even monitor themselves at home too. So that, that self-monitoring, the things that they can do outside of our clinic is so great. So I love that the new technology is coming out. It sounds really exciting.
They could do this at TSA, Karli.
Yeah.
When we get on the plane, they could do it to us. I'm teasing about that. But, scientifically, it's valid. So, in fact, Steve Heimsfield has done studies and validated this against the DEXA. And it is more accurate than impedance, another way that we frequently use it. It's more accurate compared to DEXA. So I'm hoping this will take off.
Yeah, I read that study after we last talked, and I was like, wow, that's amazing that it's even better than BIA. So definitely very exciting developments coming up.
Yeah, and you can talk. You could interview Steve Heimsfield too.
Okay, you're giving me great ideas here. Perfect. So I have a question for you. So I saw that the World Obesity Federation's World Obesity Atlas 2023 was just released. In fact, I did my last episode on the release of that report. And it revealed that U.S. adult obesity rates are expected to reach 58% by 2035, and that obesity rates in the US amongst adults are climbing at 2.1% annually, and for children, even higher, 2.4% annually. And obviously, we see the economic impact that that's going to have. It's projected to be about, 4% of the GDP by 2035, which is more than what the COVID pandemic was in 2020.
Yes.
So let's talk about the multi-trillion-dollar question. What can we do? What can we do to prevent this? And I'm asking you this impossible question because I think if anybody can help us answer it, it's you. But yeah, what do you think we can do?
I think there is some evidence out there from other countries. Clearly, the place to start is in children. Mm-hmm. That once you develop obesity, it is very difficult to reverse. And so all of our prevention sort of strategies tend not to be very effective in adults. They could stop weight gain, but they are not the prevention strategies are not very good about weight loss in adults. So to me, the sweet spot is in children, and it's in very young children. Once we go through puberty, certainly, we lose all plasticity. We develop this body fat mass that we tend to defend. And as we gain weight, we defend the higher body fat mass. So to me, I think our efforts should really be in children. There are, key periods across the lifespan when we are really, we're more prone to weight gain. And so what's going on, in fact, before birth, in utero, is very important. So I think optimizing nutritional status during pregnancy is important. Very early in life, the first 6 months of life are key. Breastfeeding and the best nutrition we can come up with during that period should be a focus. There's again something that occurs around 2 to 4 years old called adiposity rebound. And that's another sort of key time that's very important. But we do see across childhood, some children sort of become super gainers. And I think earlier intervention in those children would be key, because those are the kids who become the adults who have severe obesity. There is such a powerful obesogenic environment going on. If you look at all adults from age 20 to 40, that on average, they're going to gain for men about 25 pounds, for women about 20 pounds. That's a lot of weight gain.
Yeah.
And everybody's gaining. 95% of people are gaining at least one BMI unit. It's just a testament to the power of this obesogenic environment. The way we got here is, I think, the way out. So I think we do need to work with the food companies who've been great about being able to feed 8 billion people in the world. Right. But we need to work at healthier food choices. Reformulate. We need to reformulate. We need to, it shouldn't be entirely our responsibility to try to figure out what's in foods and what's the best food to eat. We need to be able to produce a healthier food environment for people. And that involves engaging companies that make foods. It's also, we need to work on our built environment. When I was a kid, we walked to school. That would never be done now. We need to have sidewalks. We need to have bike lanes. We need to design our living spaces that encourage physical activity. We need all of these wonderful electronics that we have. We need to make those electronics make us work a little.
Yeah.
We need the Wii game, not just the game that's exercising the thumbs. Yeah. So, I think there are many, many things that need to happen to help reverse this. It is, I think the thing that people don't understand is that it's multiple factors are driving obesity. And one little thing like front of package labeling has a minimal effect. It takes really many factors need to be addressed. There is one thing that I'll mention, and that is the social determinants of health. We know that individuals who live in environments where poverty exists, where discrimination exists, where lack of health care exists, any barriers to those things that we should all be taking for granted, that when people are exposed to those adverse social determinants, that their risk for obesity increases. And therefore we need to create an environment of economic and social justice for everyone. I think the stress of the modern environment is no doubt a contributor, and we need to address that stress for our most vulnerable people.
Absolutely. Yes, you're so right. And there's so many different factors. And thank you for bringing up all of those really crucial points. And I always think of this as like a giant puzzle, right? And it's all these little puzzle pieces that we're putting together. Yeah. Millions of little things, but they all make a difference. So thank you so much. So on to the next topic of education. So we're finding that there's still very little education amongst physicians, amongst NPs and PAs in their medical training, right? So let's discuss the next huge problem. What do you think needs to happen to address this? Because, now we're starting to have these medications. We're learning so much more about obesity. We know that obesity is the most prevalent chronic condition in the United States and worldwide. And yet there is still such scarcity of training amongst medical providers.
Absolutely.
How can we change that? I know it's difficult to get it into the curriculum because there's so many different things that we need to learn, but it must become a priority. How do you think we can make it a priority?
Yeah, the curriculum is like frozen. It's very difficult to wedge something new in the curriculum. You have to push something out. So I do think that the availability of these new tools, the availability of effective tools like medications and bariatric surgery, and even some of our new procedures in bariatric surgeries, and even devices, I think that, that is going to stimulate education. In a way, Karli, I hate to say this, but, if you don't have an effective treatment, there's not a lot of impetus to educate people about it. What do they need to know? They can't do anything about it. So I do think the difference is going to be made by having tools that work. I think we're already seeing this. There's just huge interest among healthcare professionals in these new drugs, and I see that as a positive thing. I think they're going to pursue more understanding about obesity because of that. I can't tell you how many times I get asked the question, well, how long do we have to take these new medicines?
Yes.
Karli.
Every time, right?
No. How long do you have to take a statin? How long do you have to take a blood pressure medicine?
Yeah.
How long do you have to keep taking that Botox?
You have to keep taking it for it to work. It's like, how many times do you have to shower? It's like, you have to keep doing it.
Yeah, I do think that there is so much room for research in obesity too. And just on that question, how can we better manage maintenance of weight loss? Mm-hmm. So our medicines are really good at achieving weight loss, but does everybody need to keep taking them? Is there another strategy that we could use for some patients who may not need to keep taking them? We see the data from the studies where when patients are on the drug and they're blindly taking off the drug, you can see that there's weight regain. But if patients knew that they were at risk for weight regain, could they use other strategies? Could we use some of the strategies that we've learned from the National Weight Control Registry, like lots of physical activity? Could some patients not need to take those medications? And how do we define who they are in advance? So I think there's lots of research that needs to be done in that particular arena.
Yeah, I agree. And right now it's just still kind of, until we have that research, it's kind of just taking each patient as they come,
That's right.
individualizing that treatment. And that's kind of the
Yeah.
discussion that I have with patients, because providers ask that questions, but patients ask it too, right? How long am I going to
Yeah.
have to be on this? And especially if they've had significant weight reduction and their weight's been stable for a while, they want to know, can I try to get off of this medication? So if a patient's interested in getting off of a medication, I'll have that discussion with them and I'll say, well,
Mm.
this is what the studies show typically happens. And this is what we
Mhm.
understand about the biology and why it is so common for people to regain weight, after weight reduction and when they stop these medications. But every person's an individual. And perhaps that patient
Mhm.
has really been, has incorporated a lot of physical activity or has incorporated other changes. And I think that resetting of the set point is still something that we don't know enough about yet,
Yeah.
but might be individual for each patient too. So then I might do a trial. And then I just always make sure to tell them, let's make sure we're following up more closely as we take you off of this medication. And if you find that you're struggling with your appetite, if we find that your weight is coming back up, then we always have the option to go back on it or to try another medication in that weight maintenance period. So that's, I guess, how we
I
need to approach it for now.
I so much agree with you. The way I think about it is that the set point is in harmony with the environment.
Right.
If you change the environment, maybe you can change your set point. So the reason I started thinking in this way is I saw patients who lost weight and were more successful in weight loss maintenance. This is back in the old days where it was just with, just with lifestyle alone, or sometimes lifestyle and medication. And what I observed was that patients who really had engaged in a new lifestyle that had a lot more physical activity, they seemed to do better. One of the participants in Look Ahead, for example, changed her job. She had a desk job and she became a horse trainer at the racetrack. A lot of physical activity in that job. And she was able to sustain a lot of weight loss, about 60 pounds over the long term. So it's possible. And we need to think, and I like your attitude of let's personalize it. Let's work with every patient.
Yeah. And I think it's so important what you mentioned: physical activity, nutrition, sleep, stress, all of those things are biological signals that affect the brain, that are going to affect even that appetite center of the brain. So if we're changing those signals, maybe we can change that set point. But again, like you said, I mean, there's so much research that has been done, so much thanks to you for doing so much of that research. And yet it always seems like the more we know, the more we realize that we don't know, right?
That's exactly right. Yeah.
Awesome. Well, thank you so much for being with us today. And do you have any last words of advice or wisdom for any of the clinicians who are listening to this, who are maybe thinking about getting involved in obesity management?
Yes. Here's my advice. Keep listening to Karli Burridge. She knows what she's talking about. I, I thought this was so interesting, Karli. There's so much to learn. We're not there yet, but we've come a long way in understanding what obesity really is. You and I both changed our minds about it, and I hope that all your listeners will change their minds too.
Thank you so much for joining us on the Gaining Health podcast. Don't forget to review and subscribe, and if you really liked it, consider supporting us on Patreon. Lastly, if you need resources and tools to help you start an obesity management program, be sure to check out gaininghealth.com. Thank you, and we'll see you next time on the Gaining Health podcast.